Imagine being just 8 years old and having to translate your parents' medical appointments. That is the uncomfortable role that Kayathiri Ganeshamoorthy played as a child living in Paris.
It's very scary, especially when you need to deliver new information and new diagnosis. It's lots of pressure.
Her parents had fled Sri Lankan war, and Kaya, who was born in France, became their only link between their Tamil language and French, and the risk of errors, she admits, was great.
There were prescription of medications and, I had to go through the side effects with my parents, and I didn't know really exactly the meaning and, if it was safe.
Kaya's life took her in a fascinating direction, and you'll hear more about that in a bit, so stay tuned. But what's really important about her story is that it signals this risk of harm among patients who don't fully understand the language that's being spoken. In fact, data from the Canadian Institute for Health Information zeroed in on these healthcare hotspots, finding that, no surprise, people who don't speak English or French are 30% more likely to experience a harmful event while in hospital. And there are also higher rates of harms among those who didn't graduate from high school and among older patients. This is an analysis of what's called health equity in medical care, a new microscope for analyzing and then fixing these problems, according to researcher Ross Baker.
Equity and safety now are becoming increasingly linked, and we're seeing a growing literature on the extent to which people have to now take a equity lens on these problems of safety.
Welcome to the Canadian Health Information Podcast. I'm Avis Favaro, the host of this conversation. A note, the opinions expressed here don't necessarily reflect those of CIHI, but it is an open discussion. And this episode looks at medical errors from new angles and how critical information may be lost in translation. First up, Dr. Baker, who has spent much of his career studying and trying to prevent medical errors. He's a professor emeritus at the University of Toronto. Ross, how are you?
I'm great, Avis. How are you doing?
Good. We've talked about patient safety many years, you and I, starting back in 2004, when, for me, you put patient safety on the map with that first study that looked at harm. What did you find back then in terms of patient safety at the hospital setting?
The study was done in 5 provinces across the country, and we looked at 4 hospitals in each of those provinces, so 20 hospitals. So we said, let's start there and then we'll expand, which is what happened later on.
So what did you find in that study?
What we found was that 7.5% of hospital patients were experiencing unintended harm as part of their experience in hospital, right? And most people assume that if you went to a hospital, you're going to get excellent care, which I think is the case. But there was a substantial number of patients who were unintentionally harmed during the course of their care. So that would include things like surgical complications. It would include things like medication errors. Those were the 2 most common events.
I remember at the time that there was a hue and cry after your study because that amounts to a lot of people.
There's over 2 million hospital admissions across the country every year in the early 2000s when we were doing this study. And so if you take 7% and you multiply that, you see a large number that appears. And one of the things that we did, which really hadn't been done before, was to try to apply the data from our study to the broader Canadian population to get an estimate of the incidence, the number of adverse events across the country.
And by my math, that's 140,000 Canadians harmed while in hospital. And it seemed to me to usher in the era of data, and data being really important for patient safety. Am I right?
Yeah, that's exactly right. And in fact, although hospitals were submitting data to CIHI at the time, there wasn't a focus on the kinds of events that we were looking at. So this was a new statistic that was being provided to the country. It's very expensive reviewing hospital charts. And today we're lucky because we can use other sources, including CIHI data and the more recent development of the Hospital Harm Index, which is based on the discharge abstract database that CIHI maintains. But it should be noted that measure, the hospital harm measure, is not as complete as the measures that we were looking at. And so now there's an effort underway to develop new algorithms that can be applied to that database that will give us a more complete measure of hospital harm.
So, in the 2+ decades since that data came out, how far have we come in terms of patient safety?
Well, it's a really interesting story because in Canada and in other countries, the United States and England, which were kind of early adopters of the patient safety work, there was a feeling that now that we knew that there was a problem and there was an evidence base around what kinds of things could be used to reduce the incidence of adverse events in hospitals, we thought, give us a couple of years and we'll greatly decrease the number of these that we have across the country. It turned out to be much harder, and a number of people now have spent quite a bit of time thinking about why that's the case. Part of the reason is that there's so many different types of events. So it's not like it's one problem that you can focus on. It's quite challenging, and you need to be engaging people across the hospital who, by the way, are very busy, very pressured by their daily work environments already. So saying, it's everybody's job to look at patient safety is a challenge for people who have really full work days as clinicians working in hospital environments.
Absolutely. It's very hard when you see the stories coming out from hospitals and emergency units. I kind of wonder about the patient safety data, but that brings me to a study that you were involved in recently that estimated that still nearly 1 in 10 hospitalized patients experience some sort of harm, and just under 3% involve a death. So the rates, I believe you wrote in the report, the rates as of 2021 have not changed much. Does that disappoint you, worry you?
I think it says that we need to refocus on patient safety. So you asked what we did and what we accomplished, and the early years were heady years where we thought we have a problem, we have some answers, and we had a national commitment to work on this, right? And we had many teams across the country that participated in that for a number of years, and we collect data on the impact of those initiatives on patient safety, and it was showing promising results. So that was the period in the 6 to 8 years following the adverse event study.
Yeah, I was going to say, what happened? Are people less interested in patient safety, or other things have taken priority?
Both of those, I would say. And, COVID was obviously a very important event in this and created a lot of anxiety, a lot of extra work, and the safety work didn't stop, but was harder to maintain, especially in environments where there wasn't a lot of staff who understood how to address safety issues.
So you're still working on patient safety, and CIHI is still collecting data on harms. And there were the big harms that were initially identified, but it's almost like now they're zeroing into the smaller components of harm. So in the latest report, they found that people who don't speak English or French have a 30% higher risk of encountering a negative or dangerous event while they're in hospital. So like less obvious levels of harm. Is this part of the flow of learning?
Absolutely, Avis. I mean, it's a very critical element. And when we did our study in 2004, we didn't ask the questions of who's more likely to be harmed. We asked the question, how much harm is there? And there was an assumption in that everybody was equally vulnerable. But the reality is not that. The reality is, as you've said, people with certain characteristics, they don't speak English or French, they don't have the same levels of education, or their income is lower, can be more vulnerable. And that points towards initiatives that are necessary to really ensure that communication between clinicians and patients and family members is done well, that we're really spending the extra time with people who don't understand French or English to explain to them what to do, to engage them in their care, is much more challenging when you have that language barrier.
So what is it about the communication in the healthcare system that's required in order to preserve safety?
I think this is an important issue, and it's become emphasized not only in the safety work, but in the patient engagement work, that we have to remember that it's not enough to have expertise on the point of view of professionals and other staff. We also have to make sure that the patient has the same useful knowledge about what they're dealing with and how to react to that. Because the amount of time we spend with professionals, either in hospital or outside of hospitals and community-based care, is relatively small. And so it's not just access to care, it's an understanding of what the needs of the patient are within the care environment and at home as well, outside of that. And that's equity and safety now are becoming increasingly linked, and we're seeing a growing literature on the extent to which people have to now take a equity lens on these problems of safety. So it becomes an important element of this.
Patient harm is not just an airy-fairy thing. It's also very expensive. Some of the data was showing that the average cost of hospitalization for a patient was more than 4 times that of a patient just going in for a procedure. This is a money issue as well as a patient safety issue, correct?
It is, absolutely. And, to me, I think it's very important that connection be stressed, because we've seen governments across the country start to become very worried about patient safety because it really looks like a stain on the system. And many governments have learned that if there are large patient safety problems and they respond to them, they get hit by large requests for additional initiatives that are going to address those safety problems. And what we have to emphasize is the other side of the coin. The other side of the coin is you're paying a lot for the current level of safety events across the system. You could save a lot if we could figure out how to deal with these in an effective and efficient manner. And so I think focusing on safety as an economic drain as well as a healthcare problem, I think is really important.
Mm-hmm. So if there was more emphasis put on safety, how much could we save, ballpark, nationally?
I would have to think about that for a while, but it's tens, if not hundreds of millions of dollars.
Okay, last question is, what comes next?
I think we just have to be a little more focused on things that work. And we have to recognize that, all the interventions we have around safety are built on the assumption that we can improve communication between providers and patients. So the safety work has to be designed to fit into what are already busy clinical events. And in the work that I do on governance, I'm always saying to people who serve on boards of any healthcare organization that they need to be thinking about safety as a critical element. And even when they're talking about non-safety issues, budgetary issues, HHR issues, they need to ask the question, what are the safety implications of the decision that we're going to make here, right? If we're hiring new staff, are those staff prepared to work in an environment? How do we support them? How do we make sure that they're going to be able to do the right care, the safe care for the patients in our environment? And who can help them to make sure that happens?
Very important. Thank you so much for your time, Ross. I really appreciate it.
Okay.
One of the key findings in this CIHI report is how a patient's basic language may put them at risk of harm in hospital because they may not be able to express their symptoms or even understand the treatments. So now we're going to introduce you to a program underway in Alberta.
Hi there, my name is Amanda. I'm your nurse for today.
Do you speak French?
I don't, but I could get an interpreter for you if you like.
Oui.
Okay, let's call an interpreter.
Please hold for an interpreter.
You're listening to a nurse contacting a medical interpreter on a computer tablet right at the patient's bedside. It's all to ensure that there are no mistakes and that they understand their medical diagnosis or treatment in the patient's own language.
Thank you for calling. This is Jacob. I'll be your French interpreter today.
Hi there, Jacob. We are doing a call today just to get somebody on the line who can help us out. Hi there, my name is Amanda. I'm your nurse for today.
Bonjour, mon nom c'est Amanda. Je suis votre infirmière aujourd'hui.
And remember Kaya, that 8-year-old who translated the doctor's appointments for her parents? She now has the most appropriate job heading this program dubbed Translator on Wheels.
Merci beaucoup.
Thank you so much.
Let me start first with your name and your title.
My name is Kayathiri Ganeshamoorthy, and I go by Kaya, and I'm the provincial lead for interpretation and translation services at Alberta Health Services.
Your work as a translator started when you were 8 years old, I understand. What were
Yes.
you doing translating medical terminology when you were 8?
I was born and raised in France. And yeah, I was that ad hoc interpreter for my parents whenever they had any medical appointments and translating for them.
And how does an 8-year-old translate that? Were you worried? I mean, I'm sure you realize if it's medical information, it's pretty important information.
It is lots of pressure, but I really had that duty to help my parents as they had that language barrier.
So you had to translate from French to Tamil. Were you ever worried as a child that maybe you were translating something wrong and it would lead to a problem for your parents?
Absolutely. It's very scary, especially when you need to deliver new information and new diagnosis. And I don't know, maybe that's how I was so inclined and to do my degree in healthcare later on.
Was there ever any possibility that there was harm?
Definitely, there were situations where there were prescription of medications and I had to go through the side effects with my parents. And I didn't know really exactly the meaning and if it was safe for my dad to take those medication properly. And lots of back and forth with the healthcare team in order to make sure, my dad was safe. Yeah.
Yeah. So it's no surprise to you then, given your experience, that when CIHI finds out that patients who don't speak English or French in Canada are 30% more likely to have a harmful event during their hospital stay.
Yes, this is my lived experience. And unfortunately, this is the reality of many children of immigrants and that they have to interpret or translate for their loved one. And so that's why I'm very grateful to be in this role of advocacy and in sharing best practices. And so that we have this program in place to share the importance of using a professional medical interpreter.
So your program is called Interpreter on Wheels because it's literally that. You actually have an iPad on an IV pole.
Yeah, so it's an iPad, a tablet that is on a pole on wheels. And so that you can just wheel at the bedside of the patient and you just select the language and within, a few seconds to up to a couple of minutes, you have an interpreter, a professional interpreter on the screen.
How many languages do you have to translate for in Alberta?
So the service offers 242 languages, including sign language.
That's a lot. And how many minutes of translation have you done?
So that will be around 500,000 minutes
Fi-
monthly.
That's a lot of minutes of it.
L-
And what's the array of languages? Like, what's the most common? What's the least common language?
So I would say the most common will be Arabic, Spanish, Ukrainian, and then rare languages. We will have Blin, Osa, Kurmanji,
Where are those languages from?
from Eritrea, from Nigeria. So very unique languages, yes.
And dialects,
And
right.
dialects, absolutely.
And what about indigenous languages?
Yes, indigenous languages is also one of the service we support indigenous peoples with. And for example, for Cree, you will have different dialect as well. So it's not just, identifying the language, but also identifying the sub-language or the dialect also attached to that language.
Do you have any sense that this is making the communication and the patient stay in hospital safer so that you're reducing some of that 30% risk?
Absolutely.
How do you know that?
So we have many data in terms of health outcome. There is a more adherence to the treatment plan. There is a more understanding, and it really empowers patient to really ask those questions in their preferred language. I always say when I'm sick, I'm not bilingual. I just revert to my first language, to my language of comfort when you are, in a situation, high emotion, and you need to convey how you are feeling in that moment. You just revert to your mother tongue. It's just such a natural, organic way.
So, from what I hear, the staff like the translator on wheels so much they've actually given it a name.
Yes, absolutely.
They
And yes,
personify it. What
yes,
was one of the names?
it was Sheldon, Sheldon the interpreter.
And that's what they say, go get Sheldon?
Yes, go get Sheldon. So first time, really, I got off guard. I was like, who is Sheldon? And then they explained to me, yeah, this is the interpreter on wheels. I said, oh, nice. This is really good. Like you really went that next steps in terms of, giving a name and making it part of your team.
That's really funny. Um, so where does the interpreter on wheels get used?
So they can be based anywhere in the hospital. So labor and delivery, emergency department, urgent care, diagnostic and imaging. So we really look at the mapping of the hospital to make sure that they have an easy access. And so they don't spend 15 minutes trying to find the equipment.
How many interpreters on wheels do you have across the province? How many do you need to have out there?
So we have around 300 interpreters on wheels dispatched across the various hospitals and public health as well. Each hospitals have their own tablets, their own laptop. Just in case the interpreter on wheels is busy, then they can just grab their laptop and connect and have an interpreter on their screen.
Is there something about having the laptop on a pole that makes it look like a person?
A little bit, and definitely, more convenient because it's on a wheel. Then you can just incline the tablet to the right direction and the right height as well. Compared to a laptop, you need to carry it. Someone has to hold it, and it can be sometimes challenging.
Where are these people who speak these languages?
They are all over the world. Really, it's a network of around 27,000 interpreters that are all over the world, and some are based in Canada. And really, that makes it a fast on-demand service because we really need that quick connectivity to an interpreter, especially in an emergency department context, for example.
And are they trained in medical terminology?
Yes, they are trained in medical terminology.
So again, reducing the possibility of the errors. Have you ever encountered any situations where you saw that someone understood incorrect information, this service was able to fix it?
Yes, yeah, we receive some feedback from healthcare provider sharing how, critical it was, especially at discharge planning moment when we talked about medication, helping the patient understand the frequency, how to take their medicine properly when they leave the unit, as well as in that interpreter on wheels, there is this nice feature that we call a notepad feature, which is basically a whiteboard where you can ask the interpreter to type in the target language and in English little snippet of information. So for example, take 2 Tylenol twice a day with food. So they will write that in Spanish and in English, and then the patient can take a picture and they can go home and go back and be confident about how to take safely their medication.
Your hospital has had some version of this program for a number of years, but they've been promoting it recently. Is there something that's happened lately that is making this come to the forefront?
We've been seeing a surge of newcomers, immigrants in the last 3 years, and really a high demand for these interpreter on wheels, especially in those rural locations where you don't necessarily have access to a face-to-face interpreters. And just from the recent census, 1 in 4 Albertans speaks a different language than English, predominantly at home.
What else can you do to make this better, to make communications even safer? What comes next?
I think what would come next is some policy related to language access. In the United States or in Australia, they have language access policy. It's a mandate to provide a professional medical interpreter
They
to
have
anyone.
to.
They
They
have
have
to.
to.
Exactly. They have
And in
to.
Canada?
We don't have this a policy in the healthcare environment. So at this stage, it's best practices, it's recommendation, and that's really where I would see the next steps in terms of developing a policy. So it becomes we don't have to think about bringing an interpreter. It has to be just part of patient-centered care.
Do you believe this is making hospitals and the health system safer and protecting people from harm?
Absolutely.
And how
We
does that make you feel, given where you started as a child to where you are now?
It's very rewarding hearing from healthcare providers and their feedback and from patients themselves sharing their story. So very, very grateful. And yes, we'll continue to work and make sure that every Albertan can speak in their language of comfort.
Perfect. Thank you so much, Kaya.
Thank you so much, Avis.
Expect the trend to grow as more and more hospitals are adopting medical translation services, but I'll bet none of them are called Sheldon. So what more can hospitals do to improve communication with all patients, regardless of education and language? Go to the report on the CIHI website. That's at CIHI.ca. I'm Avis Favaro. Thank you for listening and talk to you next time.